Um, Melanie needs no introduction. She's our team star, glaucoma team star.
Ay, thank you. Thank you.
All right, so go ahead, Melanie. The floor is all yours.
Thank you so much. So, in case everyone's wondering why my presentation is titled Opening Pandora's Box, I don't know, maybe a lot of you have heard me say that when you are dealing with ocular trauma, it's like opening Pandora's box because you never know what you're gonna get from that box, right? So, just a reminder about like Greek mythology 101. So Pandora's box was actually a gift from the gods to Pandora, who was the first woman on Earth, and it contained all the evils of the world, which were like released when Pandora opened that box. However, the box also contained hope, which remained inside it, and symbolically, Pandora's box, it represents curiosity and desire for knowledge, but that can lead to both negative consequences and some positive outcomes, right? So the evils that came outside of the box can be seen as challenges and difficulties of life, while the hope can represent the optimism and resilience with which we can overcome all of those challenges, right? So that's why I decided to title my presentation Opening Pandora's Box, and we are gonna talk about a case of ocular trauma. Yay, that's one of my favorite subjects, and I think that it's a very like a very useful skill to have in our toolbox for it's not very usual that we see trauma cases, but whenever we do, we have to act quickly, right? So I'm going to start with my case. We have a 29-year-old Hispanic male. He first came to the clinic the 17th of March this year with a history of hurting his left eye with the branch of a tree while he was working outside 17 days previous to our consult. So the patient said that he was cutting branches of a tree with a machete, and then one of those branches accidentally hit his eye, and that happened 17 days before going to the eye center, right? So he went to he just washed his face and with water, and then he went to a pharmacy where someone there prescribed him with some eye drops, which actually didn't like really help a lot. So that's why he decided to come to our hospital, right? Past medical history was negative and past surgical history was negative, no allergies. And this is a description of the clinical examination of our patient. He had a best-corrected visual acuity of 20/20 on his right eye and hand motion on his left eye. He mentioned that he was in a lot of pain. IOP in the right eye was 16, normal digital tone in the left eye. Extraocular movement range was full in both eyes. Right eye was pretty much normal examination, and the left eye, the patient had a 2 plus conj injection, and he had a full thickness corneal laceration that extended from the 11 o'clock limbus to 7 o'clock limbus with iris and some fibrin plugging the wound. We could also see an dialysis that went from 11 o'clock to 7 o'clock. Gonioscopy was deferred at this point. We couldn't see the lens anywhere, so he's described as being aphakic. Then we were very lucky, and we were actually able to see the fundus of that eye, and we were able to see an attached retina and a normal looking optic nerve, but with very poor detail because of the corneal edema, right? I'm going to show you a picture of what the patient looked like in just a couple of minutes. So at this point, our clinical impression for this patient was an open glove injury with a corneal laceration, iridodialysis, and aphakia. And luckily, we had a intact posterior pole, so we were happy about that. And the plan for this patient was to firstly, we put an eye shield on just to protect the eye, and then we tried to accelerate taking the patient for the OR for exploration and primary closure. So this is a picture of what the patient actually looked like. I'm sorry for the poor quality of the picture, but we didn't want to like fight with the patient. He was in a lot of pain. So this picture was taken from a video that we took in the OR when the patient was like calm and he didn't feel any pain. So there you can see the corneal laceration, conjunctival injection. He had a lot of edema, and all of those like small traces that you are able to see in the parts where the cornea is clear is not actually iris, it's actually just traces of heme that we can see there. So, and as you can see also, there's no iris there, but you can see like a nice red reflex behind that cloudy cornea. So, these are your two young eye surgeons who were brave enough to take on that tough case. Pamela and I, we did the primary repair, right? So this is what we got. Oh, I'm just gonna take a few seconds to describe what we did. So firstly, we irrigated the eye with some BSS, and then we started cleaning the wound's edges. And we took all that fibrin out. We didn't excise any uveal tissue, so we just cleaned the edges of the wound, and then we did a small peritomy just to make sure that the wound wasn't extending posterior to the limbus. It just came up to the limbus on both sides, so we were happy about that. Then we decided to close first the limbus first on both sides, and then we started to close the corneal wound with white spaced corneal stitches. We did some small corneal incisions just to be able to access the AC. And then we put in some viscoelastic to try to like form the AC. We first did a viscotite closure, and then we started cleaning all of the vitreous because there was some vitreous prolapse into that was coming up to the corneal wound. So we cleaned that up, and then we decided to wash everything out with BSS. And finally, we try to like resuture some places where the cornea was still leaking just to make it watertight. And in the end, we decided to put in a soft contact bandage lens just to make sure to cover the wound because there was a lot of edema. So I don't really have a picture, but I'm gonna describe what we were looking at during the first day post-op. So visual acuity was Count's fingers at 1 feet. IOP was taken with an eye keratometer. It was 6 millimeters of mercury. So patient had still 2+ conj injection. The contact lens was in place. He was cidal negative. He had 1+ corneal edema and edema, lots of edema of the borders of the wound, but it was closed. We had a formed AC with 2+ cells, and we had no iris visible at this point, and the fundus was only described with having red reflex. So patient was feeling a lot better. He wasn't in any pain anymore. So we started him on antibiotics, topical and oral antibiotics. We also did steroids and cycloplegics for that patient. Then here's a description of what the patient looked like 3 weeks post-op. He was seen just some days before I went down to Nuevo Progreso this last time because this is like a very recent case. So at that point, visual acuity was hand motion, but the chart describes that the patient he had like a potential like a visual acuity potential test done with a plus 18 diopter lens, and he reached an visual acuity of 2400 with that lens. So that tells us a lot about the prognostics for this patient. He has a lot of visual potential, so we're happy about that. IOP at this point was 12. So slit lamp was described with 1+ conj injection, cidal negative, sutures were in situ. There's a description of some remnants of nasal iris, but the rest of the eye doesn't have like any iris. So he probably had a lot of prolapsed uveal tissue. And when we were doing the primary repair, we couldn't see the lens, and the lens wasn't like in the posterior pole either. So my guess is that when the patient got hit with the branch, the piece of branch that came out took out the lens and some of the uveal tissue, and that's why we don't have like a lot of the structures of the normal anatomy. So aphakia, and they described it with an attached retina. So we're happy about that. Patient was left taking doxycycline by mouth. We started tapering the steroids, uh, and he is scheduled for an appointment at the clinic in a couple of weeks from now. And we're gonna see how he does, but I hope that he does a very nice recovery from now on. So
And
he's a very
Melanie,
good, yeah.
sorry, just to interrupt. Andy has his hand up. Do you
Oh,
want to
Oh,
sure.
say
it's
something?
a yeah, Melly, can you just show that photograph of the injury that you had a second ago?
Of course.
I just want to see if trying to understand where so I think I can draw in here. Is this the is this the laceration right here?
Yeah, from
And
limbus to
it,
limbus.
and when you're saying red reflex, is that what this is up here?
Like, no, it's like, let me see. Can I sketch here?
I think so.
Yeah, I think I can point. So, can you see my pointer there
Yeah.
or?
Yeah, we can see
So
that.
all of this is just like the cornea that's not affected. These are traces of heme, and behind that, there's just vitreous, and that like
Oh,
yellowish reflex is like the red reflex from the retina. So we
I see.
don't really have
So
skin.
that's not iris there.
Not that's just heme. Yeah,
Oh, interesting. Okay.
yeah.
So
Andy,
can
did
you
you get a glimpse of the wound, where the wound is at? In between the wound where the cornea is separated there, you get a red reflex right there as well.
Here.
No, down in inferior on the picture a little bit more, right? Right there, right?
So, this is actually some uveal tissue that's incarcerated in the wound, and this
Yeah.
is like the wound edges are here from here to here and here to here, but there was a lot of edema. So the wound is actually being tampinated by fibrin and some uveal tissue and some vitreous. So
so
that's what
there's no uveal tissue there at all then.
not really.
I
Yeah.
see. I see.
Mm-hmm.
Okay. Okay.
Yeah.
I got you.
Yeah.
Yeah. Good. Thanks.
Sure. Thank you for that clarification because I know it's kind of like a blurry picture. Okay, so we're gonna talk a little bit about ocular trauma, and we're gonna discuss some basic principles of open glove wounds. So eye trauma is a leading cause of preventable visual impairment and blindness. So globally, there is an estimation of 55 million injuries that occur annually, and of those injuries, 750,000 hospitalizations are required, and of those patients, 1.9 million of them, they're gonna end up with low vision or even blindness from ocular injuries. So open glove injuries are a subset of ocular trauma, and they tend to be more visually devastating. They require surgical repair, and they also come with a greater economic burden. So knowing all of this, that's why it is so important that we know how to approach these cases the best possible way, because like the first time that the patient comes into the clinic, when the patient has an injury, then that's like the best chance that you have to help him to do as well as he can. So open glove injuries are full thickness defects of the eye wall, and they are often differentiated by mechanism of injury. So they can be sharp or they can be blunt injuries. We're going to discuss a little bit further on those terms, and they are ocular emergencies, and they can lead to substantial visual morbidity. So without timely intervention, damage tends to be irreversible, and that's why it is like so important for us to like identify ocular open glove injuries as quickly as possible. So although the incidence rate of OGIs is pretty low, with a rate at 3.5 per 100,000 people globally, the consequences can be devastating, and they can lead to significant morbidity, and as I said, permanent disability. So the potential for vision loss is a primary concern in these cases, and that is why early diagnosis and management are critical in preventing vision loss. So OGIs are primarily classified using standardized terminology describing blunt or sharp mechanisms of injury, as I said. So the first subset are ruptured gloves that refer to blunt trauma, where there is a high IOP that ruptures the weak points of the eye wall through an inside-out mechanism. So usually this type of injuries, they tend to occur most often behind the rectus muscle insertions or at other weak points of the eye. And some of them are the limbus, the optic nerve, and prior surgical sites. And then there's the other type of wounds that are lacerations, and lacerations refer to OGIs that are caused by sharp trauma where an object cuts or punctures the eye, and it causes an injury through an outside-in mechanism. So as you can see, it's different from the blunt injuries. And although lacerations are termed sharps, it includes any mechanism that directly penetrates the eye wall. For example, gunshot wounds, they are described as laceration. And lacerations finally can be further described as perforating injuries, which are injuries that have a related entry and exit wound. When there are penetrating injuries where there's only like an entry wound, and there's another subset that's called intraocular foreign bodies, in which the offending object remains inside the eye, and that is why it is called intraocular foreign body. So another classification for this type of injuries can be based on the clinical findings and the anatomic location of the wounds. So we have to take into account visual acuity, the presence or absence of APD in case we can like examine that of that patient, and the anatomical zone that is affected. So zone 1 refers to the whole cornea, zone 2 refers to all of the space that's between the limbus and 5 millimeters posterior to the limbus, and zone 3 refers to all of the tissue that is beyond 5 millimeters posterior to the limbus. Because, I mean, knowing that, you know which structures are probably going to be affected. So that's why it is important to always describe the zone of the injury. The evaluation of these injuries has several goals. One of them is identifying the mechanism of injury. Then we're going to need to characterize the extent of the injury, and finally gather relevant history. And that should be done quickly, and because we need to expedite preparations for immediate surgery, or surgery as fast as we can get it for the patient. So in the evaluation, history is important because in cases where there is significant ocular trauma, an OGI is presumed until proven otherwise. Also, if there is mention that the wound included like a sharp object or a high velocity projectile, forceful blunt trauma, explosives, fireworks, all of those tend to be like cases where there's gonna be an OGI associated with the trauma. And also we have to take into account the history of the patient. For example, patients who have different medical conditions such as Ehlers-Danlos or osteogenesis imperfecta, they are patients who are like more prone to be to have OGIs. Also, patients who have a history of ocular surgery where they had previous large incisions. For example, patients who had an M6, an extra cap, a radial keratotomy, or a PK. All of those patients, they have like weaker structures where they can have an OGI. And also we need to ask about the setting of the injury, timing of the injury, the allergies that the patient might have, immunization status, and also the time of last ingestion, just to prepare the patient for the OR. So the physical exam should include visual acuity, APD testing, as I said, slit lamp examination, fundus examination whenever it is possible. Any pressure on the eye should be avoided. And also in cases of really small lacerations, or where we are not sure if the corneal wound is affected the whole thickness of the cornea, we can do a sidle test, but this is contraindicated in cases where the OGI is like very obvious, right? So I just I really like this picture because it's really funny, you know, slit lamp examination, however you can get it done. So imaging. Sometimes we need imaging studies to help us diagnose OGIs, or to understand the extent of the damage, or to rule out if there is any intraocular foreign body. And like the ideal test for this type of injuries is a non-contrast orbital or maxillofacial CT. This has a very high specificity and moderate sensibility for detecting OGIs. And the findings that we're going to look for in this type of imaging are changes in the glove contour and vitreous hemorrhage, intraocular air, the presence of intraocular bodies, and abnormal anterior chamber depth. So this is a really cool picture that shows us some of those findings. The first picture, the one that's labeled A, there you can see a very common sign in an OGI that's called a mushroom sign, and some intraconal air, that's the right eye that's affected. Then on the B picture, the picture that's labeled B, then we can see a vitreous hyperattenuation, which probably corresponds to hemovitreous. Then in the picture labeled C, there you can see a metallic intraocular foreign body, and that's a very classic image. And finally, in the picture labeled D, there's just a comparison between the depth measure of the AC in the right eye versus the left eye, and there you can see that there's a differential of almost 1 millimeter, and that's very suggestive of an OGI. So there are other imaging modalities, for example, the B-scan ultrasound, but this is not advised for confirmed open gloves. Although it can be performed like cautiously by expert hands. I mean, if you have an OGI, then it's not very advisable, especially if the wound is very large, then you should not apply pressure to it. So MRI is contraindicated. It's said to be contraindicated because of the time needed for the testing, and also especially in cases where there is suspicion of metallic intraocular foreign bodies. And finally, there's mention of conventional views on plain film X-rays, but these are usually not helpful for diagnosing OGIs. So management, as I said, one of the first steps that we should take is to avoid further injury. Once we have a diagnosis of an OGI, then since infection risk in these patients is high, then we should start empiric systemic antibiotics. That's why it is important to know if the patient has any allergies. Also, we should try to expedite surgical exploration and primary closure whenever possible for the patient. And after this first step is done, then we can consider if the patient is going to need secondary surgery and revision, followed by extensive follow-up. Some considerations for the pre-op management are that the repair should be done within the first 12 to 24 hours after the injury. General anesthesia is usually the preferred type of anesthesia for these cases. So in cases where there are protruding foreign bodies, they tend to act as tamponades. So the removal of those foreign bodies should be reserved for the OR. We should always place an eye shield just for the patient to cover that injured eye, just to make sure we don't cause any more intraocular content prolapse. Also, we should ask about the tetanus immunization status. And it is also important to remember that OGIs are painful and they are often associated with episodes of emesis. So that's something that we should consider to medicate our patient in order to make them feel more comfortable and avoid further extrusion of intraocular contents. So for the general surgical approach, first, usually you start irrigation with BSS of the injury. Irrigation should be done gently, just so that we don't push or don't extrude any more intraocular contents. Then sometimes if we don't see where the wound starts or ends, then aperitomy is required to expose and inspect the sclera, just to make sure we're seeing the edges of the wound. And when there are injuries that go underneath the rectus muscle insertions, then the tendons of the rectus muscles should be disinserted, and then we repair the sclera, and then we have to reinsert all of those muscles back. Usually when there is iris or other uveal tissue prolapse, that should not be excised unless it is like clearly devitalized. then we can use viscoelastic and an iris or a cyclodialysis spatula just to gently put back any uveal tissue that's extruding. Then in the cases where there is injuries with violated lens capsule, then maybe we should consider doing a cataract extraction as well during that primary repair. And if it can't be done at that primary repair, then the patient should be scheduled for cataract extraction as soon as possible in order to avoid any uveitis associated with the particles of the lens, and also secondary glaucoma. And finally, if there's prolapsed vitreous, then the patient should have an anterior vitrectomy done. Of course, these are just general approaches, right? So patients should be considered as on an individual basis. So some repairs are complex and they may require multiple surgeries, right? So the first of the goals of the primary repair are to secure watertight wound closure and to reestablish anatomical relationships as best as possible. We always have to clean the wound edges just to avoid getting complications such as endothelial ingrowth or downgrowth. Then one of the first steps that we can perform is to making the glove viscotight and then adjust the sutures when we wash out the viscoelastic to make it finally watertight. And as I said, usually the first sutures that we throw in when we're repairing a wound, they're gonna get loose when we're like getting close to finishing it, or we're gonna have to change some of those, so we're gonna need to refine the sutures as we go. And finally, remember the suggested suture sizes for the different anatomical places. And for cornea, it is best to use non-absorbable sutures such as nylon, 10-0 nylon for cornea, 9-0 nylon for the limbus, then 8-0 nylon for the anterior sclera, and 7-0 nylon for the posterior sclera. There are some cases in which, for example, in small children or people who are really it's gonna be tough to remove the sutures after, then it is described that we can use vicryl sutures because they have the durability needed for like good healing of wounds. But personally, I've never used vicryl to close cornea, for example, or limbus, but that's what I read, so I just put it out there in case anyone wants to comment afterwards. As I said at first, prioritize aligning the limbus first. That's gonna give you, like, always remember anatomical landmarks. That's gonna be making your closure a little bit easier. Linear wounds should be approximated with sequential bisecting sutures, and you can approach complex and stellate wound trying to do the linear components of the complex wounds, and then maybe try to do a purse suture afterwards to approach the stellate portion of the wound. Whether in cases where there's like wound intersections that cannot be closed by sutures, like as a final resource, we can use cyanoacrylate glue, and after drying up the part or the place that we're doing the glue on, and then put in a soft contact bandage lens just to help the closure watertight. And as I said, initial sutures may be and should be replaced as needed at the end of the case. So sutures should be placed perpendicular to the wound and on the cornea, especially closer to the visual axis. And in irregular wounds, we should use shorter sutures and closely spaced sutures. The adjoint tissue should meet perpendicularly. I'm gonna show you like a picture on the next slide that's gonna help that's gonna help me explain all of this that I am mentioning. Whenever we can, we should do partial thickness sutures. It's preferable because we don't want, if we do like full thickness sutures, then we can create another infection entry site into the eye. And we have to tightly trim and bury the nuts, usually away from the visual axis. And also this is important when we have oblique angle injuries, then we have to throw in the suture, favoring the overriding side of the suture first. It's gonna look asymmetrical if you look at it from the outside, but it's gonna get like a better closure of the wound in cases of like oblique wounds. So this is just like a drawing that depicts everything that I just mentioned. And there's also this here in the picture in the H here. This is whenever there's injuries where we have loss of tissue and we need to do, for example, a scleral patch. This is trying to like show us that the scleral patch should go overriding the edges of the wound. So like this and not like this, like in the second picture. This is another picture that just sums up everything that we just mentioned about the closure.
Hey, Melanie, can you go back one photograph there?
Here?
One more.
Yeah.
I think that's a great photograph.
I love it. Yeah.
Yeah. I'm just had one comment on that, and that is in this image, all the knots are buried, which is fine. You know, there's people have different philosophies about burying or not burying. And you know, if you bury them, then you have to remove them at some point. So you may run into a little more difficulty because the wounds in these traumatic eyes can tend to be more fibrotic and inflamed. So you can make a case if it's going to be short term to leave the knot closer to the surface. And then my other comment I just is that I don't think you mentioned this, but I'll often when I'm repairing these use slip knots. So, you know, as you close it centrally with a slip knot, you can then put a few different slip knots in, get the wound approximated, and adjust the tension. And that allows you to kind of work throughout the wound in several different places at the same, you know, without committing yourself to the final tension that the 3-1-1 knot creates. So anyway, I think a slip knot is a really good pearl to add into trauma closures. Thanks.
Sure. That makes a lot of sense. Thank you for that. And also, I think it avoids like changing a lot of sutures,
Yeah.
like when you're getting like the wound closed as you go, right? So, okay, this is important. Primary enucleation or evisceration is not recommended to be done like at first unless it's like absolutely necessary. And it is actually mentioned that sometimes you even want to like defer that procedure because we need to talk to the patient, discuss it with the patient, and also to help the patient get like starting to like, digest the idea of losing the eye. So it's usually not recommended for a first approach, but sometimes it is necessary. And this is another important point that the cornea is an optical surface and it requires special treatment. Hence, we treat it with lots of care. And so any suture that's in the cornea has a potential to leave scarring and it is ideally minimized, right? So for post-op management, topical antibiotics, corticosteroids, and cycloplegics are used. In contaminated or complex repairs, then usually subconjunctival antibiotics are recommended, and systemic antibiotics should be continued for at least 24 hours. It can be used for up to 7 to 10 days, depending on the case. And some of the recommended antibiotics are IV vancomycin and ceftazidime, and some fluoroquinolones can be used in patients who are allergic to penicillin. And this protocol tends to minimize or reduce the risk of post-traumatic endophthalmitis. So follow-up day 1, then we need to monitor the watertight seal. And then if needed to, then plan for secondary repair or secondary intervention. Also, severe complications must be ruled out because they can result in the loss of a viable eye. And in cases where it was impossible to see the posterior pole during the first examination, then once we have our primary repair done, then we can do a fundus examination or a gentle B scan just to make sure how everything is going up behind the eye. Finally, so here are my take-home points for you. So as I said, timely evaluation and treatment of OGIs is necessary to reduce vision morbidity and mortality. Evaluation should be done quickly to identify OGIs and characterize the injury. Adequate surgical exploration and repair must result in a fully watertight seal, as I mentioned. We also mentioned this at first, that OGIs have a huge cost to the individual, the workforce, the healthcare system, and society. And we should always collaborate to make sure that people understand like secure practices, for example, for people who tend to work in places where these type of injuries are more common. And something that has helped me a lot is to always remember your anatomic landmarks. Always keep your patients comfortable and calm, because people that are coming to ask for help, they are scared, they are worried, and they're in a lot of pain. And that's not good for them, and it's not good for us either, because it's going to be harder to manage those patients, and we can get like more extrusion of the intraocular contents if we don't help our patients. And finally, this is a very important point. Don't forget to check the good eye or the non-injured eye, because that's gonna be the eye that's gonna probably have like the best visual potential from both eyes, especially if there is risk of losing the injured eye. So in case there is anything that we must and should be addressing like quickly also in the non-injured eye, then we should see it like as quickly as we can. These are my references. And thank you so much for listening to me. I'm sorry if I talk too much or too fast.
Thanks
Thank you,
for a
Melanie.
great presentation. That was really complete and extensive and hit a lot of super important points. Thank you. That was great. I have just a couple comments. One kind of ties into what you were just saying, is that I always try to remember in encountering these cases that it's most likely that I'm meeting this individual for the first time on the worst day of their life. And that does require a lot of interpersonal sensitivity to the fact that, hey, this is the worst day of their life ever. And so I just wanted to throw that out. The other comment, I like Andy, I love the diagrams of the sutures. Those, everybody should study those who's not familiar with them. One thing I've noticed over the years is that the sclera, when you get these scleral ruptures, they don't look anything like the diagrams at all, because they're not surgical wounds. There's something unique about the scleral architecture, is that the layers of the sclera, especially a blunt force trauma, are ripping like this. They're not just tearing like a piece of paper, they're ripping, and you're getting fibers here and fibers here that are pulling apart. And so sometimes to close those, you almost have to overlay them a little bit, depending on the status of the underlying choroid and retina and so forth. But to get a watertight seal, you're dealing with just like wispy fragments of sclera by the time it gets torn. But anyway, that takes some creativity. But thanks for a great presentation.
Thank you.
Yeah, Melanie, that was great. Really appreciated that. Just a question on that case. So I was with the antibiotics. I was wondering, at the time of the initial repair, did you all use intracameral moxifloxacin? And then afterwards, I think you mentioned he was on doxycycline.
Yeah, but like I didn't mention that, but we did use intracameral moxifloxacin during the primary repair, and then we started the patient on oral fluoroquinolones. We used levofloxacin on that patient, and then we started the doxycycline when Dr. Sima was down at Nuevo Progreso, saw the patient, and she suggested doing the doxycycline. Yeah,
Yeah. Okay. Great. Thanks.
thank you.
I would like just to add one last little comment, Melanie. Here in Guatemala, I don't know what's going on in the US, but here in Guatemala, we're starting to document these cases. Because even if this patient doesn't report there was any intentional trauma, like somebody hit him with a stick, but I think we should start taking pictures. We have the technology to take pictures and in the videos. I mean, you did, and I think that's great. Just as a take home point, just add, we should document these cases more thoroughly. in Guatemala. Now the insurance companies are going crazy with all these requests. You know, they want us to use fundus cameras to document retinal tear, to cover a peripheral argon laser for a horseshoe tear. So it's crazy. They're asking all these for pictures and for everything, the videos of the surgery. So I'm just throwing this out because in trauma, it's important to document all these things. I don't know if you guys are experimenting that in the US, but insurance companies here are, what I say is, you know, the only sure thing of this insurance is that you're going to get charged, but everything else, you're not sure about that. But yeah.
Okay, I think you're about 30 years behind us for insurance interfering with the management of the patients.
Okay.
So just consider yourself lucky.
Bill, I have one question for you. You know, the thing that was most startling to me is that it was 17 days. He had this for 17 days before he came in, which is unimaginable to me. But
Yeah.
had he come earlier, do you think there was any difference in your treatment or the outcome had he been earlier? Or would you feel like he would have had the same treatment, same outcome, same course of action?
So I think the approach, I wouldn't approach it differently. We did what we were supposed to do. We took him to the OR quickly. We did a primary repair. We did as much as we could during the first intervention. So I think approach-wise, I wouldn't change it. He's doing really well considering like a really bad injury, and also that he came like so late after the initial event. But maybe regarding the part of the prognosis for this patient, I think that getting the surgery done like before all of those days had gone by, like as I mentioned, like in the first 12 to 24 hours, then maybe surgery would have been a lot easier. Maybe we could have been able to salvage some more uveal tissue, because apparently he had some extrusion of that tissue. We don't know if it happened at the primary injury, or maybe all of those days that he spent at home doing whatever he wanted to do, and you know, like without knowing what was actually going on. So maybe that would be different, and maybe but I'm not sure if that would like ultimately change the result. I think, I mean, for what we had, this patient was very lucky, because he could have even developed like a really bad endophthalmitis, and he didn't, because it was like trauma with a vegetable. So as I said, I don't think that the prognosis would have changed much, but definitely the surgery would have been a lot easier without all of that edema, without all of that fibrin. And maybe, as I said, we could have salvaged some more uveal tissue, but I'm not sure. It's hard to tell like at this point. But I think it's a very very interesting question just to consider.
Thank you, Melanie. Thank you for the presentation and all the great questions, everybody.
Thank you.
Thanks for being here. Staying a little longer.
Sorry.
Oh, that's great. Oh, we had a great discussion. Thanks.
Great presentation, Melanie. I often give this talk to my residents, and yours was far more comprehensive. So I might show them a tape version of yours.
Thank you. You're too kind. Thank you.
Thank you.
All right, guys.
Thanks, everybody.
Thanks for staying.
That's great.
Good night.